Okay, we're now going to switch gears to another special presentation from Dr. Hodis and NIA.
Thank you, Helen. It's great for NIH to be adding its informational input to this very exciting array of progress that we've been hearing from members of the group, federal partners included. Today, I'd like to focus on the FY 2025 professional judgment budget. This is something we've been doing each year for the past years. And the next slide, please. It's just a reminder of where the professional judgment budget language comes from. It requires that the NIH director issue each year an analysis of the additional funds over current baseline that are necessary to achieve progress at maximal efficiency towards the goals of NAPA, essentially, including the identification of prevention, cure, care and services around Alzheimer's and related dementias. Next slide, please. The process then each year begins like this. It's 2012 to 23 meetings. We've had a series of summits, many of you have participated, which identify the opportunities, gaps in research needed to achieve the goals of the national plan. These are then translated into a series of milestones, the achievements of which are necessary to accomplish those goals, estimates of the funds needed for each of those milestones, all of which are compiled into a professional judgment budget estimate shown here. Next, please. So the framework for categorizing the milestones and goals of the national plan, and for us, the bypass budget, are revolved around CADRO. It's a common Alzheimer's disease research ontology that was generated by NIA in collaboration with the Alzheimer's Association and puts together a way in which to organize the various components of needed research. These also feed into IDROP, an international Alzheimer's disease research portfolio, which now includes research supported by many nations across the world, a large majority of the research focused on Alzheimer's and related dementias. Next, please. This then is the summary being released now officially at this moment for the FY 2025 bypass budget. And you can see that there are dollar figures, targets for each of the goals. We'll go into those in a little more specific detail. They add up to a total cost that are needed for research above and beyond current resources, current being defined essentially as the FY 23 operating levels. And then with a reduction for the amount of funding that will become available because of previous goals accomplished, funding for which therefore becomes available for new initiatives. If we can turn to the next slide, which shows it again, then here in the summary you can see the current estimated FY 23 total NIH investment in Alzheimer's disease is some $3.7 billion. The total requested additional funds needed are $318 million, which would bring a total in FY 25 of $4.1 billion approximately. And the next slide. This is shown as a pie chart, which breaks down the contributions in various areas. And I'll go through each of these with some exemplary points. Next slide, please. So as I mentioned, 6 research areas with an additional cross-cutting area, epidemiology and population studies, disease mechanisms, diagnosis, assessment, and monitoring, translational research with clinical interventions, dementia care and impact of disease, research resources, and then a cross-cutting international studies topic. Next, please. So some examples and bullets here under each of the areas I mentioned in epidemiology and population studies. And stressing again, these are just examples, and I'll direct you to the full and comprehensive set of them. To find and develop novel new tools to better understand environmental factors and deploy complementary approaches to explore how infectious disease, notably viruses, may be playing a role in contributing to dementia, particularly timely in the context of the COVID-19 pandemic. In disease mechanisms, funding innovative research to better understand mechanisms including RNA modifications and examining the vascular contributions to dementias. Next, please. Diagnosis, assessment, and treatment, a very exciting area in which we're looking at digital as well as biological technologies to understand biomarkers that help us to identify and track the course of disease and its response to treatment. translational and clinical interventions. A great bit in the news that we'll be talking about of finding the way in which our basic targeting can be translated into early and then definitive clinical trials and interventions. Next, please. Dementia care and impact, subject of a lot of what we're discussing. I can tell you that we now have over 200, in fact, clinical trials that are targeting aspects of care and support for those living with disease and their caregivers. Research resources, and then, as I mentioned, the international studies, beginning to look, even as we develop interventions that are effective in the United States, in well-financed and developed countries, to paying attention to the fact that this global pattern needs particularly targeted attention towards countries where the resources may not sustain some of the aspects of diagnosis and treatment that we have in progress. And so trying to make the approaches to diagnosis, treatment, and support those most amenable in reality to the real-world situations of global populations. Next, please. Next. In addition to the bypass budget document, we are now issuing a separate document, which is a narrative that relates progress in areas that I alluded to. And I show you the link here, but it summarizes significant NIH-funded dementia research over the past decade, put in perspective all that's been accomplished under the aegis of this advisory council advising NIH and NIA. Next slide, please. Some of the accomplishments, advancing our understanding of the disease risk factors and genetics, which has led in turn to identifying biomarkers and new targets for treatment, accelerating drug repurposing and combination therapies. The new tools allow early diagnosis, a focus important for prevention, advancing clinical research on lifestyle and other non-pharmacologic interventions, increasing our understanding of how social and environmental factors among them can contribute to dementia risk and disparities, and expanding our research on dementia care and care partner support. Next, please. Next slide. So important to all of this, and the resource we share with you is our ability to track progress. So here is a new site available, which allows identification of each of the milestones that are particularly involved in our plan to address Alzheimer's-related dementias. For each of them, ability to identify the targeted goals necessary to achieve that milestone, the progress status in each of them updated. And iDrop, the other resource I refer you to, is one in which we can search at various levels of specificity all of the aspects of Alzheimer's-related research that are occurring globally. Next, please. And next. That's just one example of the means that we take to support research beyond the usual grants and solicitations, is the use of challenge mechanisms. Here, the upcoming Eureka Challenge that will be focused on early prediction and innovation toward that end, important as we've been hearing this morning to areas such as early detection and prevention. It's anticipated launch date in September, and we'll keep you all informed of this, where awards are open to any and all, hopefully innovative and new areas of science and people who might not previously have been involved in these research domains to bring their talents, skills, and ingenuity to the purpose. Next, please. Now I'd like to ask if either Walter.
Hello, I guess.
Okay. Well, either Walter or
shall I go ahead? Okay.
Rod, take it away.
Sure thing. So thank you, Richard, for the opportunity, and to the Napa Council for the opportunity to just say a few words about NINDS's activities that are in collaboration with the NIA and responsive to the national plan to address Alzheimer's disease. And I just want to say that in fiscal year 2023, NINDS led 14 funding announcements, and these are responsive to the implementation milestones that come from the NIH ADRD summits and that are in the national plan. Looking forward toward fiscal year 2024, we have funding initiatives across the research spectrum, and I'll just say a couple words about some specific ones, as well as workforce development, diversity, training, and career. Next slide, please. So in terms of equity and diversity, in blue at the top, you see 2 initiatives out of the 3 are specifically focused on that theme, and we're really moving forward actively in that area, and also on disease mechanisms. And we have a number of initiatives planned for fiscal year 2024 that really embrace the scientific reality, the reality recognized by the council and by the Healthy Brain Initiative that was described today, about the multiple potential pathways and risk factors for dementia. And in particular, the first on this list that's in orange about blood-brain barrier response to antibodies targeting beta amyloid. This is part of NINDS's efforts to continue to both recognize the passive immunotherapy efforts that are moving forward, including with FDA approval, and to also look toward paying attention to what's happening with the blood-brain barrier, and looking to decrease risk as much as we can through understanding molecular mechanisms. Next slide, please. We also have initiatives on clinical trials, clinical research, and translation. And the 2 that I want to just mention quickly here, the second one from the bottom in green, anti-amyloid efficacy and Alzheimer's disease-related dementias, in particular with vascular contributions to cognitive impairment and dementia. This is a phase 3 clinical trial initiative, and this is again recognizing the potential of anti-beta amyloid passive immunotherapy and helping move that toward kind of integrating the multiple potential pathways that can contribute to dementia in any particular individual and across diverse populations. And also along that theme, the last initiative that's listed in green, we have the title is Simultaneous and Synergistic Multiple Target Validation for Alzheimer's Disease-Related Dementias. And then this initiative again is embracing this emergent finding that has come since the advent of the national plan, that there are multiple pathways that are likely activated or active in a given person that contribute to dementia, and that part of the serious endeavor of doing something about that is recognizing that and trying to do something about that in individuals. So for more information about NINDS's funding initiatives that are responsive to the national plan, you have a barcode here. And we always want to tell people that it isn't necessary to respond to a particular targeted initiative. We always welcome investigator-initiated research. Next slide, please. I also, in closing, in terms of NINDS's updates today, I want to mention that there is going to be a workshop on September 28th to 29th. It's going to be both in person and virtual, and the point of contact is Dr. Francesca Bassetti. This is about anti-beta amyloid passive immunotherapy and amyloid-related imaging abnormalities, kind of what's next, like the initiative that I mentioned on a previous slide. The NINDS wants to help contribute to understanding mechanisms of blood-brain barrier injury associated with anti-beta amyloid passive immunotherapy, understand patients at risk for ARIA, what are the comorbidities, treatments, possible potential factors such as anticoagulants, and potential therapeutic strategies and research ideas to protect patients at risk. So this is in collaboration, of course, with the NIA and with others. And we hope to see some of you at the workshop, either virtually or in person. And we know some of you are collaborating and participating in the workshop, and thank you for that. Those are my updates. I'll pass it back to you, Richard.
Thank you, Rod. And the next slide. This is just on behalf of all of us at NIH, a series of links to allow you to stay in touch with all that we are doing, including, as I've mentioned to you, the links to our latest initiatives, to the bypass budget itself, And with that, I think Rod and I will be open to any questions if there are any from the group.
You guys are off the hook.
Thank you for the opportunity to add to an exciting day.
Thank you.
Thanks, everybody.
Okay, I'm turning it over to Sarah Fontaine. We have 4 more federal updates, so everyone, thanks for sticking with us.
Well, this is a bit of a tough act to follow because I also fund medical research for the Alzheimer's and Alzheimer's disease-related dementias, but through the Department of Defense. So my name is Sarah Fontaine. I am the program manager for the peer-reviewed Alzheimer's research program. We're housed within the congressionally directed medical research programs within the DoD. And I know it's been some time since we've given a federal update, so I'm going to go ahead and just do a really quick snapshot of who we are for anybody who maybe doesn't remember or doesn't know that the DoD funds Alzheimer's research, amongst other things. And then I'll talk to you about our current initiatives that we have going on, as I'm really excited to share those with you. So if we can go to the next slide. So CDMRP is an interesting organization. We started about 30 years ago, and we were basically the result of a grassroots effort by breast cancer research survivors to fund research differently and to do things a little bit differently. You can see our vision and our mission here. These are really important to us, truly to work to transform healthcare through innovation and impact, looking at research that really addresses those. So if you move to the next slide, I can talk a little bit about how we do this. This is our newest logo. Like many others, we like to change these up frequently. So like I said, CDMRP started about in 1992. We coordinate and collaborate with a lot of folks in this room to really try and find that high impact, really near term, useful biomedical research. We fund research around the world. We don't have any restrictions on types of organizations or countries that we can fund. We have a 2-tier review process, and the really important thing about the 2-tier review process is that at each step of the way, we involve individuals who are living with or caring for somebody with that disease, disorder, or condition. And I'm going to touch on that a little bit more later. But really, we kind of try and keep sort of a solution-based approach in mind. We're really trying to find those cures, improvements, breakthroughs, anything that we can really do to make the lives of people who are currently impacted by the diseases, and I say diseases, I'll get to that in a minute, just really try to improve that as much as we can. So we're different from the NIH because we are a sort of special add by Congress to the end of the DoD budget. So we work on completely different dollars, and we are really directed by Congress every single year with an appropriation and a charge of what it is that they want us to concentrate on. So that means that every year we have to adapt our strategy depending on how much money we get that year, and we spend all of our funds for research up front. And so my program particularly spends about 97% of its annual appropriation on research. We run pretty lean so that we can put as much money towards research as possible. We also work really hard with other funding agencies to make sure we are not duplicating effort, and everything that we do is publicly competed. So you can find all of this information on our website. And the rest of it is just a couple of other bullet points that, depending on who our audience is, we'd like to hit, but everybody can read those. If you go to the next slide, slide after that, I forgot to say next slide, but so our FY23 appropriation was $1.5 billion. It covered 35 different research programs. So I sort of highlighted in pink, I realize it's a little bit hard to read, the neurological related ones. And so you can see everything from ALS to multiple sclerosis and traumatic brain injury, and the amount were appropriated each year. I add ALS because I also manage the ALS research program. But each one of these programs has a specific line item that's written into the defense budget, and they are each run by a program manager who annually adjusts based on our appropriation and the needs in the field. So that's a little bit about CDMRP, where we came from, how we operate. If you would go to the next slide, I'll talk a little bit about the peer-reviewed Alzheimer's program. Now, I had to give a talk not that long ago that was titled, "Yes, the DoD does fund Alzheimer's research." I wish I was kidding, but I'm not, because while we've been around since fiscal year 2011, not many researchers have heard of us, which is really unfortunate. So I put my PR hat on this year. So we have had a total through to include the 23 appropriation of $189 million. So that does seem a little bit like small potatoes, but I will explain how we put this to really good use compared to the NIH. And really what we're doing is we're looking at that intersection between military service, traumatic brain injury, and trying to understand how those factors lead to increased incidence of Alzheimer's disease and related dementias. And so we have a sort of two-pronged mission, really looking at a couple of priorities that I can talk about in a little bit, but really to figure out, why is this happening? What can we do to treat it? What can we do to reduce risk? And then how can we improve the quality of life for those who are living with the dementias? And I include the related dementias in that. And how do we reduce burden on the caregivers and their family support? So if we go to the next slide, this is a little bit of a snapshot that I have to present annually, so I just added it just for scale. You can see that the NIH does cover down really well in this area, and we are very grateful that they have the ability to do so. And what I do want to point out, though, is that this is for Alzheimer's disease overall. If we go to the very next slide, you can see that when we focus it down onto the TBI-related research, so this was using the CADRO ontology that Richard was talking about. It looks a little bit different from the graph that I just showed you. So there are color codes. The teal area is NIH, the yellow is the VA, and the purple is my program, the peer-reviewed Alzheimer's program. And you can see that while the NIH and the VA are really leading the way in molecular pathogenesis, really kind of understanding the mechanistic insight and common mechanisms that are related to dementia, so looking for those common themes that maybe we can use to target for therapeutics. The PRARP has a really focused investment in the diagnosis, epidemiology, and dementia care and impact of disease when we're looking at this TBI-focused AD research. And so this is where we have traditionally focused, and I want to talk a little bit about where we're going next. So if you could go to the next slide. I like colors, so sorry about that. This is a color-coded slide that kind of details sort of where we've been and where we're going. And so each fiscal year, so this represents one appropriation that we've gotten for each fiscal year. We've had a variety of different priorities that we've focused on. And as you see moving through to FY23, we have sort of changed focus a little bit. So while we still maintain that early diagnosis is critical, and so is the individual, family, and care support focus, we have begun to address the disparity in the populations of clinical research that we have. So particularly in the Army, it's actually really striking the demographics of the service members now compared to the demographics that you may have thought about traditionally. And so what we're seeing is any equal amount of data supporting the more diverse service members. So I'm looking at a situation where I may not have the data I need to help service members as they age, based on the sort of heterogeneous data that we have right now. So we're making a really big push to make sure that our data is representative of the people we're trying to serve. We are now focusing much more on risk reduction and overall sort of brain health to try and intervene earlier and find ways that we can reduce the overall incidence of dementia in service members, which I will mention. It's not actually the service members that you would be super worried about. It would be the veterans. And depending on your race and ethnicity, you have somewhere between a 2 to 8 times higher risk of developing dementia if you've served in the military. That's a lot. And so it's really, really important for my program to really help address in that space. So moving on, if we can go to the next stage, I'll talk a little bit about, I talked a little bit about caregivers. And so caregivers and people living with dementia, they're sometimes referred to in my organization as consumers. So I do apologize now for that, for everybody. I prefer to think of them as folks who have the lived experience that's necessary to do the work. So we involve them not just at the peer review level, where they're actually reviewing the proposals and providing their insight on, is this going to be impactful? But also they make the funding recommendations. So I actually have 4 individuals, 2 caregivers and 2 military veterans who have early onset Alzheimer's, who are on my programmatic panel. They are the ones who choose which applications are funded every year. And then taking that one step further, every single one of the applications which comes in that is proposing clinical research, so anything having to do with any sort of human population, I require them to have an element of community collaboration as necessary for getting funding from me. So this can look like a number of different things. I leave it up to the investigator to choose the appropriate model of community collaboration for what they're studying, but it is a non-negotiable for the program. And we have actually gotten some really, really important and great feedback from that approach. So I'm happy to hear any other comments on it, but I do truly think this is really important. So right now we've got 3 award mechanisms that we issue. So we focus on diagnosis, care, and then research. You can see the FY23 levels are listed on there. And then this awesome acronym that's called SITPO. And so if you go to the next stage, next slide, I'll go ahead and talk about that. This is our attempt to build capacity within the within this research area. So it's a partnering PI option. I'm in the DoD, so we love acronyms just so very much. So I apologize for that acronym. But what this really is that we are asking 2 collaborating PIs to work together on one research project. So they will share the total budget, but each one of them is given a reward to their institution. And this is really important because what we're doing is focusing on career initiation or career transition. So people who are transitioning into working in the Alzheimer's field, or new investigators who are 3 or more years out from their terminal degree, but no more than 7 into an independent position. And the reason that we chose that is when I was at the bench, that's the stage that killed me. So that was the hard part of anything that required assistant professor level for me. You know, that was really hard as non-tenure track faculty. So what I decided to do was try and eliminate some of those barriers. So I wanted you to get through your first postdoc, so you had your feet wet. But then I don't actually have I have no care, whatever your title is, it's what it is. If you propose the best research, then you will get funded. So this is our way of making sure that each PI is getting an award in their name, which is incredibly important for career trajectory, but still working collaboratively on projects and promoting a team science approach. And then I think I think this is working so far. So when we look at the next slide, this is our current roundup of when we started efforts looking into supporting newer investigators and what's the output of that is. So from FY17 to FY22, we've invested $8.2 million in new investigators through a couple of different mechanisms. And then as we sort of go through this arrow, you can see that a quarter of them were promoted or received tenure if they were non-tenured. We've got 59 publications so far that are the direct result of our funding. The citation rates of our supported new investigators have increased over 160% from when they started. They're getting more citations every year past their funding. And we have a ridiculous return on investment. So our investigators have been very successful at getting larger follow-on funding, continuing their lines of research, and 100% of them are still in the ADR field. So we're very proud of that, truly making sure that we're trying to contribute to keeping that research capacity where it needs to be so that we have the right bright minds who are working towards all of the goals of the National Alzheimer's Project Act. So I think I've got one more slide. These are just a couple of outcomes from this last year. So 72 publications overall from our funded investigators, 2 patent applications, which is really fun. Just this year, we had 5 investigators obtain further funding for the projects that they were working on with us, and a new biotech company started up based on successes from one of the awards that we had supported them for. So with that, I'm happy to take any questions anybody might have, but thank you very much for your attention and for letting me speak today.
Joanna, as a veteran, I have an esoteric question for you. When you talked about I think you said 8-fold increase of risk for veterans, did you parse that out between veterans that were involved in the draft versus those that came in after when the volunteer service began? Is there a difference?
There's not as much of a difference. So the 8-fold increase is if you are an African American woman, you have an 8 times higher risk of developing dementia if you've served. So we do have data which is from sort of the pre-Vietnam era and then from post. But overall, when we roll it all up, it lands at about 2.5%.
Hi, Sarah. Thank you for that presentation. Has there been enough time for the research findings to turn into implementation, either for the risk reduction and or care components?
So for the care component, yes. So we've been funding, we actually, one of my favorite successes is back in 2016, we funded an investigator from San Francisco, and she started a Tai Chi based intervention. And she actually then took it in an FY19 award even further and paired it with not just MRIs, but a community partner. So actually the intervention is now community led, and she's collecting outcomes with them. And it's incredibly successful. So they're actually seeing improvements in not just depression, anxiety, and neuroimaging outcomes, but also the loneliness and social isolation. And this was really critical because she had to run most of her trial during the pandemic. So she's working on how to scale that up more because it has been so successful. We've also got a couple other ones that are sort of VA-based caregiver interventions. And one of them just got funded by one of my sister programs, the TBI program, to do a phase 3 trial based on that same approach and just looking at a very slightly different population. So we do have some, we don't have as much advancement in the sort of pure research, foundational research side. I feel like that is a little bit too soon there, but our care awards are really, really going places. And this year, for anybody who receives a care award from us, they are required to manualize their intervention. I can thank Erin for that. She is on my programmatic panel, so that we can actually facilitate transitions up front. And then for our diagnostic award, I'm actually requiring a community meeting with the investigator and the community that they are trying to address to talk about their concerns, what they're interested in, what they need to see for diagnosis. And that's in the first year before they actually start collecting data to make sure that that feedback is incorporated into the design. So I'm happy to talk to anybody who has any other ideas, because I am able to every year adjust and improve. So yeah, I'm looking forward to future stuff. This year, I will say, I have to say this because I'm so excited. We've received the most applications that we have ever received in the history of the program this year. So next year, I'm hoping to report out on some really exciting projects we funded.
Thank you. Okay. Oh, I didn't share all your slides. Okay, IHS.
Thank you so much. I think it feels like we're like the not research element here, the boots on the ground folks. So thank you. It's actually nice to be reporting on behalf of a team. I think it's been Bruce for years and years. So for Valerie, myself, and Dr. Roniak and Bruce, excited to be here. Next slide, please. I know that you guys have seen this slide a number of times in Bruce's past updates. This represents the 4 major priority areas of our work that were created as a result of tribal consultation and urban conferral conducted in 2021, which was just after our initial appropriations. The ovals themselves actually represent an approximation of scale in terms of funding and resource allocation based on the tribal priorities. You'll note here that the largest priority for funding is getting the money out to the communities, the tribal communities and urban Indian health communities, to develop models of care for people living with dementia and their caregivers. According to tribal and urban Indian health leaders, the second largest priority is workforce development, including discipline-specific education and training about dementia, diagnosis, awareness, and then training in caregiver services and support. And then you'll also see outreach and awareness, and then finally program support and data. And that's really about data to drive implementation activities, not kind of more ubiquitous data. I think on the congressional side of things, they have a really big interest in prevalence and incidence numbers, but as everyone can imagine, that's a little tough for us to track down on our side. As a reminder, 2021 was the first time IHS has ever received directed appropriations for actually any type of elder-focused activities, and those funds were specifically earmarked for Alzheimer's work. I have to say I'm a little jealous because we got $5 million in 21, and I think Sarah was mentioning her little budget relative to NIH, so we should be friends, Sarah. As we mentioned, our biggest circle are grants and program awards. In 2022, we were excited to fund 4 awardees. We funded everyone who applied that year. We're about to enter the second year of those cooperative agreements. For those grantees, year 1 was really focused on infrastructure building, collaborations, and staff training for those programs. Those guys there was really little happening in their communities and in their clinics with respect to dementia. Healthcare workforce shortages continue to really devastate these rural and smaller communities. Even in our urban areas, they continue to see workforce shortages that are wreaking havoc. I mean, we saw clinics who were like, hey, we're going to hire a nurse to fill this role, who ultimately are hiring CHRs, who in some instances said, we'll take anybody who has an inclination to do this work at this point. So some have, kind of stuck to their guns, and it took 9 to 10 months to hire into the positions. They have an emphasis on hiring people from their communities, and so we respect that in that space. But as you can imagine, that presents startup challenges, particularly for 2-year grants. We are wrapping up our 2023 Notice of Funding Opportunities like ACL and CDC, and imminently hope to announce our awards. We were excited that we nearly tripled our applicants this year, which is exciting for us, even though we're talking about small numbers, but that was exciting. Hope to be announcing by mid-month. We will fund a minimum of 6, but fingers crossed we can do a little better on that space. I forgot, forward ahead, if you don't mind, slide. Yeah. So that's just a rundown of what I was just talking about there. You can see a list of our 2022 awardees and then some details about the 23 awards. Next slide. Workforce development, I have a couple slides on that. I think, we put a lot of emphasis on that in the last 8 or 9 months, really recognizing that developing clinical champions and building tribal capacity in this space is a big priority. We're focusing on tribal capacity building, I think, and clinical champions via the grant, but also some really concerted efforts in this space, both planning and piloting new activities. You've heard Bruce talk about our first cohort of Indian Health Jerry Scholars. Those folks have completed their local improvement projects this summer that culminated in presentations on dementia, medication reconciliation, and falls prevention. Just as a reminder, this program is modeled after the highly successful VA Jerry Scholars program that's led by Dr. Josie Kramer. Some of our scholars come from really low resource rural clinics. In some instances, there are only one or two providers in those clinics. Asking them to step away from their clinical space to work on a project is a little challenging, but they did it, and that's been kind of a cool experience for them. It's been a really rewarding experience, both for the scholars as well as for Bruce and Valerie, who have been their mentors one-on-one in these experiences over the last 6 or 7 months. At the same time as we were closing out those projects, we were also recruiting for our second cohort as part of this pilot, and we're excited to say we have 16 new scholars in our second cohort. They'll start this fall. They represent 7 IHS facilities, 6 tribal clinics, and 1 urban site across 7 IHS areas. We also wrapped up a 6-month intensive pilot that we conducted with the IHS Division of Oral Health. And we tested the use of the MiniCog screening tool in dental practices. The bottom line was we found it could be done. It was a really simple question, and we just didn't know if it could happen, and we did it. The screenings were trigger or risk-based. It wasn't focused on universal screening. One of the other aims was trying to identify opportunities to adapt dental care and practice as a result of identifying potential cognitive impairment issues. Not necessarily referring on, but like, does my dental care need to change? My practice need to change? And the answer was yes. Of those screened, 20% screened positive and resulted in referral. What's kind of cool about IHS dental sites or ITU dental sites is because the dental sites are almost exclusively co-located in primary care. Those dental sites are also able to follow up on referrals. Not all dental patients are also clinic patients. But almost all were, and they were able then, in some instances, literally able to walk them to the primary care clinic and help them set up an appointment. I can't promise those appointments were followed up on, but they have an ability, I think, in that system to help close the loop in some ways. The other piece I think that you see on here, and we've talked about before, is the Geriatric ED Accreditation Initiative. We talked about the fact that we had 9 IHS and tribal EDs who completed bronze level accreditation, and we're going to continue working on that accreditation initiative with the Division of Nursing. We have interest from 4 sites for the coming year. We have 1 site who is currently bronze level who is interested in bumping up a level in the coming year. And then we have 3 new EDs who are interested in seeking bronze level accreditation. And so looking probably around the first of the year to work with those guys in that space. And we've encouraged them strongly this year to focus on dementia as for their particular project that they have to focus on. So next slide. Also, in the area of workforce development, the Division of Nursing, no surprise, my background's nursing, but forged some good relationships with those guys. We have been working on development of a geriatric nurse fellowship pilot that we hope to launch in September of 23. It's loosely modeled on the Jerry Scholars program structure, and will provide core funding, provide funding for core training, a specialty training of their choice, and a local designated project or activity, maybe not as focused as local QI type activity. The aim is really to recruit a variety of nurses from the bedside up to leadership. And another activity that's designed to support our strategy of developing clinical champions across the ITU system, recognizing that, in the care of people with dementia, nurses are really the person, soup to nuts, who provide care. So we've also been working to evaluate existing dementia-specific training opportunities. Anybody who's tried to dip their toe in that training pool recognizes and knows that there's hundreds of pay for play and free opportunities, and it's really hard to wade through that. In the spring, we had 28 advanced practice nurses take an APR-specific dementia care specialist course, and then complete an evaluation and offer their recommendations on the utility and relevance for tribal serving providers. And they gave us thumbs up all around the board. And we're now having 32 RNs complete the same course to tell us whether it's appropriate for the RN workforce. We've also been busy this spring. We've had a lot of requests from IHS service areas, as well as some individual clinical sites and clinics to talk about dementia diagnosis and primary care stuff. So I'm working in that space as well. Next slide. Still in the workforce development space, I feel like it should be our biggest bubble. But in the workforce development space, we are continuing with our ECHOs in partnership with Northwest Portland Area Indian Health Board. Right now, we anticipate this will probably go on for the next 2 years. We do the clinical ECHO, which is really focused for providers and clinical staff. Largely so far, it's been focused on diagnosis, which is the number one question that they come to the table with, is screening, diagnosis. And then eventually, I think we'll shift into care management. The typical ECHO model, where we get a little didactic, we present a case and kind of roll through that. And then we also have the caregiver support ECHO. We've really tried to reframe that one a bit, where we have, on the last one, we have public health nurses, caregiver support services, CHRs, a lot of CHRs on the last one. And instead of a case, we've sort of reframed that into a story. And so we have somebody who talks about their experience as a caregiver or a person in the clinic or in the clinical setting or community setting. So that's been pretty successful, and we've had pretty good consistency so far, and a lot of new folks showing up for that one. Next slide. And I think we're winding up here. The other piece that we had was outreach and awareness. In this space, in the spring, we hosted a 5-session webinar series. It was really to support our NOFO, to gen up some interest, get a little information out there, give them some ideas to think about as they're applying for our grants. We had ultimately 217 people participate, but almost 400 registrants. And we had folks participate from all 12 IHS regions plus beyond. In April, we also participated in ACL's Title VI Technical Assistance Training Conference with Cynthia, and Aaron's grantees were there, as well as CDC Bold grantee was there. So we had pretty much all the tribal federally funded tribal grantees who were in this space, who got into a room, and some other folks who were interested in dementia work. And it was a nice day of learning and engaging with folks. Our IHS grantees, we helped them supplement their travel, participated, and they stayed on. And our objective was really to bring our clinical grantees and help them build some community bridges. So Bruce was also able to participate in a conference-wide listening session, and the topic of dementia came up multiple times during that listening session. Just a sort of a little metric, we also host a listserv, and since the fall of 2020, we've seen a 250% increase in folks signing up for a listserv. And It's not on our slide, but one of my priorities has been using social media, and our weekend reviews hosted or posted by our director, and getting information out, because if we don't tell people, they don't know what we're doing. And so we've consistently had information out on social media, and we've early estimates from public affairs is that we've had some individual posts exceeding 30,000 reach of 25 or 30,000 on some areas. We had some older Americans posts, and so far, like in the spring, like 150,000, reach of 150,000. So next slide. That's it. There's some contact info there, pages and stuff like that. Thank you so much.
Thank you. And last but certainly not least, we have FDA and CMS for some timely updates. Teresa?
Hey, hi. I apologize if it's noisy here. We had some trees. Hold on.
For those of you who came from out of town, we had a bad storm on Saturday night at 5 o'clock that knocked down trees through the whole area, and we're still recovering.
Yeah, sorry. Hi, sorry. We had a big storm here, and I had some trees down, and a neighbor's having us all going at this time. So I just asked if they could pause for a moment. Okay, so I think my update is very well known to everybody already. So I'll just go quickly through these next few slides. And the main update here is that lecanemab, also known as Leqembi, was had an accelerated approval, and this accelerated approval was converted to a traditional approval on July 6th. Oh, thank you for letting me know you don't hear the background noise. I appreciate that. And this was based on the results from the phase 3 randomized controlled clinical trial, the Clarity AD study. And we can go to the next slide. And this was an 18-month or 78-week multi-center study that was double-blind and placebo-controlled in patients with what would be equivalent to the stages of mild cognitive impairment or mild dementia due to Alzheimer's disease. And overall, just to cut to the chase, statistically significant treatment effects were observed on all of the primary and secondary endpoints. And the primary endpoint was a clinical dementia rating scale, sum of boxes, which is an acceptable endpoint for the FDA as a clinically meaningful endpoint for a trial in early Alzheimer's disease. And this was also supported by effects on the ADAS-Cog subscale and a cognitive measure, and on the activities of daily living scale, as well as physiologic changes that were seen on brain amyloid plaque levels as measured by PET. We can go to the next slide. So basically, we used the findings of the efficacy results. We're able to confirm and verify the clinical benefit that had been the basis of approval, the basis of approval for the accelerated approval. And then the safety from the Clarity AD trial was largely consistent with the safety that was observed in the phase 2 study. But we did make some updates to the prescribing information, in addition to adding in the data from the new safety data from the Clarity AD study. We elevated the risk of ARIA had already been described in the label in the warnings and precautions, but we did elevate this up to a boxed warning. And the main reason for that was that we had an advisory committee meeting, and we heard from the advisory committee and also from our Alzheimer's disease community that they wanted to make sure that the risks of ARIA were very clearly stated in our label. We also noted that there was an increased risk of ARIA that's observed in ApoE4 homozygotes compared to non-carriers or heterozygotes. And so we wanted to call that out in the label as well for prescriber and patient awareness, just so that they can be informed. And included in previously, the label just said consider ApoE4 genotype testing to inform risk of ARIA, but we did strengthen that wording a bit to make that more of a recommendation than just a consideration. And then in the Clarity study, we did see more risk of hypersensitivity with lecanemab, so we did make that a contraindication, which had not been, it had previously been noted in the label as a risk, but not as a contraindication. And so I think that is basically covers the traditional approval for lecanemab. So I will stop here and see if there are any questions.
Hearing none, should we move on to CMS? Thank you, Teresa.
All righty. So just checking. Can you hear? Okay. All right. All right. Thank you. So continuing with the theme of, a comprehensive approach to providing access to care and services that are needed by people living with dementia, also caregivers for people living with dementia, and also to support people who are at risk of cognitive impairment and dementia, but may not have a diagnosis yet. Wanted to just continue to emphasize CMS's approach to using maximally the existing authorities of the agency. And we'll provide just a brief update on two of those authorities, one being coverage and the other being payment. So for coverage, I'm turning to Dr. Joe Hutter, who is, I see his name is on the screen, to give us a brief update on, there you go. So Joe, starting
Sure.
with you. Thank you.
Yeah, thank you, if everyone can hear me. So in April 2022, the CMS National Coverage Determination on monoclonal antibodies created a pathway for coverage with evidence development. Once any MAB or monoclonal antibody targeting amyloid gets traditional approval by FDA, again, based on evidence of clinical benefit, which we just saw Teresa present, it gets coverage under CED. There was great concern by some that there would be no vehicle for CED coverage for at least 14 months. That obviously, after the FDA decision, that obviously was not the case. Leqembi received traditional approval on July 6, as Teresa just mentioned, of this year. On the very same day, CMS launched its national registry for this CED. If we go to the next slide, actually go to the next slide after that, this is just the landing page. It's on the website now. You can look at it. I was asked to give a very simple explanation of what this CED is. So basically, the CED is not this CME registry. It includes this registry. CED is an umbrella that also includes any NIH-supported research on monoclonal antibodies and more complex in-depth studies, one of which has already been approved and is on the CMS website. When CMS reassesses CED status for any particular MAB based on its own merits in its own studies, we will look at the totality of evidence and multiple papers and likely from multiple registries. Now, David Dolan is going to just give you a very brief update on the amyloid PET PDM.
Great. Thank you, Joe. So on July 17th, CMS posted the proposed national coverage determination for beta amyloid PET and dementia and neurodegenerative disease. With this posting, CMS proposes to remove the current NCD for PET beta amyloid imaging, which would end the current coverage and evidence development requirement, as well as the current limitation of one PET beta amyloid scan per lifetime. This will permit Medicare coverage determinations for PET beta amyloid imaging to be made by Medicare administrative contractors. So the posting of this proposed decision began the 30-day public comment period. We encourage anyone that has any questions or concerns about this proposal to please submit a public comment by August 16th when the public comment period closes. And with that update, I will turn it back to Sherry.
Thank you, Joe, and thank you, David. And so the final slide, if we could have that. I just wanted to also flag for you that we have a couple of key proposals that were just published in the Federal Register. One of which is the proposal to make payments for practitioners or to practitioners for training that also involves caregivers to support people with certain diseases or illnesses, including dementia. And this includes, carrying out a treatment plan and things that are really important in the understanding of what matters and what care is needed for a individual by another individual. So this is a proposal to which we hope that we will receive comments, suggestions for, if you like it, if there's a new idea or something that should be amplified. This is the opportunity to do so, and I think these slides are going to be posted, so you don't have to worry about getting the photos. We'll also mention, though, that there's a proposal for principal illness navigation services. And what that enables is payments to help people who would require assistance navigating the healthcare system to be made for those navigation services. Now, these services can include services that would facilitate access to community services, healthcare services. I make the distinction because it's not just about a given treatment. This is about the totality of what keeps people well and that would support better health outcomes. I will flag for you that, there's a definition for high-risk condition that circles around being at least 3 months in duration, and that the condition places the individual at high risk of hospitalization, nursing home placement, acute exacerbation or decompensation or functional decline relating to a acute or chronic illness. So this again is a proposal. These two proposals, if finalized, would be implemented on January 1 of 2024. So the date until which the comment period is open is easy to remember. It's September 11th. So, we do urge you to submit comments. We also did hear, though, and this is not in PFS per se, but also a proposal. I believe it's in our outpatient prospective payment system proposal about the challenges that may arise with because of the bundling of ligands that are used for the diagnosis and management of certain conditions into a bundle. And, that is also, we didn't offer a proposal, but comment is invited about that, just anticipating that may be perceived as a barrier to access to PET diagnostic studies. And with that, I did want to also mention, we have received a variety of questions from many of you and others who are in the room about, so what is meant by, and what are the opportunities presented by this registry? Is it just one registry that is supported? I would say that this is a registry. The CMS registry is one vehicle through which coverage can be ascertained, but there are many registries that support different purposes, including research studies with much greater granularity than what is outlined in the CMS through the CMS portal. So if those studies were to enter in under CED, then that would be another pathway to access these therapeutics. We believe that these policies provide important steps towards more comprehensive and person-centered care and services. So we're very excited about all of this. So with that, I will close and thank you for the opportunity to provide the update. Back to you, Helen.
Thanks, Sherry. Questions?
Thank you so much, Sherry. On the principal illness navigator, is there a definition of what constitutes a navigator? You mentioned that there's definitions on the serious illness. Is that up to the healthcare systems to define who those?
So there is a definition. There's some proposed who's in, and we've tried to be broader than narrower. It's not just a physician or a medical professional. So take a look. It is published. I don't want to get it wrong, but it's meant to be broad. And, you know, keep in mind that public comment often gives CMS the opportunity to expand and also clarify and define. So we try to be broad in our proposals, just recognizing that there's not one correct approach that will meet every community, both urban and rural. You know, appreciate your earlier comments. So thank you. Over.
Sherry, just a quick question on the definition of the person that may get the funding from the caregiver training services. I would imagine that the physicians and those people working in the physician's office are not going to have a lot of free time to do extensive training of caregivers. I know that's maybe delegated down. Would that be billable against non-medical personnel who are doing the training under the supervision of those folks? Or is that restricted only to those who are licensed physicians and medical providers?
Yeah, so I believe what is listed thus far are in the proposal is for those services that are furnished by a physician or a non-physician practitioner, nurse practitioners, clinical nurse specialists, certified nurse physician's assistants, like clinical psychologists or therapists. In parentheses, I think what has been included as examples are physical therapists, occupational therapists, speech and language pathologists, and I think the point being, I don't think we specified who is not in. So if there are individuals that actually would be helpful but are not listed, then that could be submitted as far as a comment or a suggestion. I will also say that the services have to be under a individual treatment plan or therapy plan of care. So that is the broader umbrella to ensure that the care and services by individuals meet the needs of the person who the care should surround. So I would say, you know, that your question suggests that there may be opportunities that were not specified here, but gives us logical outgrowth with those comments. Thank you.
Sorry, this is Joan. I would just like to reiterate what Matt said. The primary care physicians, nurse practitioners, and PAs are just really, really busy, and this training is really delegated to the registered nurses in the practice and medical assistants.
Yeah, thank you for the reminder, Joan. And, you know, our hope is that all that we have developed, all that we have learned collectively over the years, those are important resources that could be brought to bear in not only providing these services, but doing it well. And I think that's really an important point. So Joan, thank you for those comments, and also your forthcoming offer to also build on what we have done together before. Thank you.
I just make a quick
Thanks, Sherry.
clarifying comment. So one thing is any comments made at this meeting do not inform the CMS process. So if you are interested in making a comment like Matt did, then you should go to the link and we'll share it and make the comment through that process.
Yeah, that's really, really important. So this can be for, it has to come in through our process. So please do submit. Yeah.
So I thank you, Sherry, for the updates. And I want to start, I think everybody knows at this point that the Alzheimer's Association doesn't necessarily agree with the CED for traditional approval, but I want to acknowledge that the registry that CMS did provide does represent a low barrier of entry, and appreciate the work that you did to ensure that as many people as possible could in this format access treatment going through that registry that is posted. In this, the caregiver training services and the principal illness navigation services seems to be really complementary to what we heard this morning on the CMMI front. So can you comment on this physician fee schedule proposal along with how that will potentially work with the CMMI projects also?
Yeah, good observation that, these are intended to be complementary. And I have to defer to my CMMI colleagues on the timing of when go is for implementation of the model. But if these proposals are finalized, however they are finalized, whether it's finalized as proposed or something expanded and different, the finalized proposals are green light of January 2024. So, these can, in whatever form, go live pretty immediately, right? Not immediately as in today, but it is known. So I will need to defer to my CMMI colleagues on, if this actually can be used to supplement or in either case, all is good because we are coordinating. We meant to coordinate. So thank you for your question. And also thank you for, the acknowledgement that there are different approaches to collecting data, if you will. And I think one of the principles that really supports the CMS registry, and for any CMS proposal, not only thinking about flexibility over time and space, but also the sensitivity to administrative burden for, documentation requirements. And we would all much prefer time that is spent, between clinicians and the people who they serve rather than, with documentation. So that was part of the thinking on how do we make this as light touch as possible. And really, we is the team who you heard from today. So thank you, Joe, David, and Joe Chin, who may also be on over.
Sherry, just a follow-up to that point, I also am delighted to hear that there's a lot of thought given into the light touch and decreasing the administrative burden of physicians and professional carers who are providing support, because we are all incredibly overwhelmed and busy, and and to add more burden really is a barrier. So like Joanne, I was delighted to see that the system that CMS rolled out was low barrier and enables specialists to proceed. One of the medical and scientific findings that we are seeing in this new era of removing amyloid plaques to change the course of the disease is that earlier treatment appears to be better. And at this year's AIC, for example, there was the publication of donanemab's results that showed that people who had low amounts of tau pathology did substantially better effect size-wise than people with higher amounts of tau pathology, even though they were all early AD, MCI, and mild Alzheimer's disease dementia. This was replicated by the lecanemab drug program, who showed nearly identical findings. And so what I think that tells us in the science and the medical community is that the timing is really quite important, and that we probably don't have the luxury of waiting a year or a few years to treat people to maximize the benefits. And so with that as the background, my question is, does the CED program enable a way to track the uptake and the treatment of appropriate patients? For example, it was launched amazingly right on July 6th. Is there data, is there some information that could be known in real time about how many people have registered, how many prescriptions have gone forward, what's happening since July 6th? I know it's but I'm just curious, in the next time, will we know what's happening with this historic launch?
Yeah, thank you so much for your question, Randy. And we are, and I don't know if the team has the latest numbers, but because the entry of a person into the registry requires a Medicare participating prescriber who we know because they put it into the system, and also Medicare beneficiary number for payment purposes. We can see what is coming in, but there's more information that we can add on to on the back end by way of Medicare claims, given the beneficiary numbers. I think all in all, though, as the evidence evolves, and a very exciting time to think about. Initially we were just focusing on amyloid, and there may still be that portion of the pathophysiology that matters too, but adding in tau or whatever comes next, I think is something that we have to be tracking and to look at to see what is the current decision, what would fit under that current decision, or is this at some point when would we and how would we revise a decision, which would again be in the public space. It's a separate issue, though, but related one, I believe, to be able to identify people early enough. And this is not the coverage policy. It is, how do we have the infrastructure and the mechanisms to actually do so within the points of care, across the points of care, in the clinical setting. So I think that is something that it's not within the realms of the coverage determination, and yet still important, because I can see how, we identify people, but they already have severe disease at the point of
I guess my question is more of a general nature. Is the CED program, is that somehow going to will there be access to NAPA or other groups to understand what's happening with the program? Will there be some transparency or access to the information?
So we will do a couple of things. One is we will, commit to providing updates so that, we can all be on the same page of what we are learning. I will also say that, we are enabling a mechanism of the data that's collected through the CMS registry to be put together with the claims data and accessible by way of the usual route for CMS data. So, that now not all data will come to CMS, right? So some of the studies that come in under CED are analyzed and looked at by the investigators. And as long as the questions are answered, then, those studies are coverable under CED. So, that is a little different on the research side that this policy enables. Hopefully that answers your question.
It does. Thank you so much.
Thank you.
All right, so thank you for all of our partners for presenting the federal updates. There's so many exciting advances here. So I think even within our short time of going over the federal updates, we heard about a lot of new collaborative comprehensive clinical care programs, public health outreach programs. They're going to link with that. We're going to hear about, while it was quick, Dr. Baracchio mentioning we just had our first full approval of a therapeutic that's disease modifying for Alzheimer's disease, and a lot of great changes to provide increased coverage and access for patients. So thank all of you for your investment in presentations today. I know that we are way over today, so we're going to aim in the next 8 minutes to finish up our AAIC updates just real briefly, and then we'll move lunch to 12:45 to 1:30 today. So 12:45 to 1:30, and then we will start there with our recommendations. So we'll just pick up a few things. I know Dr. Pike has already gone over the wonderful statistics about the AAIC meeting, the number of attendees, exciting advancements. The only other thing that I was going to just mention was the new Alzheimer's Association National Institute on Aging framework for dementia. It's listed as clinical care, but it's more clinical research guidelines for patients. And so these have been developed in 2011, 2018, and then now revised this year, and they're open for public comments. And these criteria really are changed because of the need to recognize that we now have a disease-modifying therapy that targets specific biomarkers, that we have evolving biomarkers that Randy will touch base on next. And so wanting to make sure that the guidelines reflect that. So again, there have been criteria that looked at how does the person present with their clinical staging, and then what do their biomarkers look like? And so re-emphasizing where we are with that, recognizing that people can have more advanced clinical presentations than their biomarkers suggest, which means that there's probably some other pathology in there that's not been accounted for. So for example, if somebody has severe dementia, but their Alzheimer's disease biomarkers are pretty low levels, that it probably suggests they have something, either a vascular contribution, limbic associated CDP43 encephalopathy, the late condition, or other types of dementia. And then reverse of that, if somebody's cognition is doing better than their burden of Alzheimer's pathology, that maybe there's some other protective factors that we needed to study to see why they're doing so well clinically. So it's kind of a revamping of the clinical versus pathologic criteria, and some new components. Again, in addition to recognizing and noting some of the specific measures for amyloid and tau, they also are identifying some that can be used for vascular inflammation, alpha-synuclein, and some other markers of other types of pathologies. But again, focusing in on the ones that have the most evidence. There's still work to be done with what will we do with somebody who now has received anti-amyloid therapy, so they no longer have amyloid pathology. So that, I think, is under discussions about how will we categorize that person. Will there be models such as what they use for cancer diagnosis with TNM staging? Will there be types of models like that for Alzheimer's disease? So those discussions are underway. One of the controversial points that's being discussed is that now they will label people who have disease that's detectable through biomarkers, but not clinically apparent yet, as having Alzheimer's disease. So again, the issue about the stigma that'll be associated with that, what will that do to epidemiological statistics of how many people live with Alzheimer's disease currently? And what about those who don't have access to biomarkers, who may have what looks like Alzheimer's disease, but may not have the biomarker evidence? So the papers are on the website, and we can put that link in the chat. They're open for discussion. There's a document with the article, and then some of the tables that kind of summarize the reasons that these changes were made, and some of the visuals that help us to kind of put this into context of the clinical and pathologic framework. So that was an exciting advancement, and I'm going to turn it over to Dr. Bateman to comment on biomarkers and new therapeutics.
Okay. So I'm only going to say 3 things from the AAIC meeting that I just thought was one of the most exciting meetings of my career. And I think for many of us, this represents a time where the things that we're learning and the things that are advancing year by year now within a 1-year period are transformational. It's really quite different than even last year and then the year before. So the three things that I wanted to share, and I've already mentioned some of them in the context of the question about the implementation, is that for some of the drugs that remove amyloid plaques, we're learning a lot more about the kinds of clinical and cognitive effects that they have in different kinds of people. And one of the things that has come out at this recent meeting was what I said was that it appears that people who have lower tau pathology in these studies, in general, do substantially better than people who have high amounts of tau pathology. And this is not a small magnitude of effect. It's quite large. The people with low tau pathologies can have slowings of 40% or more in our clinical and our functional scales. And so there aren't many diseases, chronic diseases, that we can treat today and slow down their progression by that magnitude, by 40%. So I think we're really approaching a much deeper understanding, and I expect that over the next few years, as we learn how to implement this and who benefits and how much they benefit, we'll be able to have even greater gains. And the future promise, of course, is that drugs like these might be able to prevent or delay the onset. I really appreciated, by the way, the presentation on secondary prevention. Might be able to prevent the onset of clinical symptoms. And that would be something really terrific. And we're already discussing, can these prevent the onset of disability and the things that would require nursing home placement and the terrible cost and the outcomes of that. So those analyses were done for the two drug programs, donanemab and lecanemab, and those were presented at the meeting. And then with that, with those drug programs, the other thing that we saw was that in cerebrospinal fluid markers and now in blood biomarkers, those programs are showing how they can track amyloid removal and other biological changes that occur. So giving us a way to track the disease process in the blood is really quite important, because we need to know, when do people become amyloid negative? How long do we need to treat for? What is the dose that we need to treat for? These questions I expect will be answered through clinical studies and outcomes, but also through measuring the biological effects of blood biomarkers. And then finally, we and others reported through several different studies, both general clinic studies as well as our study was a study in research, was that blood biomarkers now rival the performance of PET and CSF scans. So they have 95 to 97% AUC accuracies, matching PET. And what that potentially enables is it enables us to maybe use these blood biomarkers as a confirmatory test of things like amyloid plaques, and not just a screening, which was the first generation of tests. And so this will, I think, transform the access that patients and caregivers and doctors will have when it comes to early diagnosis, which is turning out, I think, to be critically important, that we need to be able to diagnose people as early as possible so they can have the maximal benefit that we can get out of these latest drugs.
Thank you, Dr. Bateman. Any questions about AAIC updates? Either Dr. Pike, Dr. Bateman, or myself? I think everyone is ready for lunch and a break. So we will reconvene at 1:30 Eastern time. So we'll have a 45-minute lunch and break. So we'll reconvene again at 1:30 Eastern. Thank you.
Produced by the U.S. Department of Health and Human Services.